Okay, so a very good evening to all of you. Welcome to this doubt solving session in pediatrics. So, if you have any doubts, I hope I'm audible and I'm clearly visible to all of you. So, if you have any of your doubts, I'm just waiting for this. So, welcome to this doubt solving session of pediatrics. If you have any doubts, please go ahead and ask your doubts. Okay, so there is a question on refeeding syndrome, and refeeding syndrome I have discussed in my classes is a condition which is associated with the sudden introduction of a very high amount of calories in a child of protein energy malnutrition. So suddenly very high amount of calories when they are introduced in a child of severe acute malnutrition, it can lead to a group of problems including hypophosphatemia, uh, hypokalemia, hypomagnesemia, and thiamine deficiency. So it's basically a group of metabolic and electrolyte abnormalities which occur when a very high amount of calories are introduced, uh, especially in children who have been having malnutrition for a very long period. So the idea is that you need to start these children on very low amount of calories and gradually, according to the tolerance, increase it according to the tolerance value. Only then you will be able to prevent this syndrome. Otherwise, if you suddenly start very high calories in a child with a previous malnutrition, not taking meals for a very long time, then it can lead to a group of abnormalities. The idea is that whenever there is a very high amount of carbohydrates or a very high calorie added to such children after a long term malnutrition, then it can lead to a sudden increase in the insulin levels, and this increase in insulin levels can also drive intracellular shift of potassium and phosphate, leading to hypokalemia and hypophosphatemia. So from extracellular there is an intracellular shift of potassium and of phosphate as well. So all of these problems are associated with a introduction of meal very high calories in a child who has been malnourished for a very long time. There will be hypophosphatemia, hypokalemia. Hypokalemia especially has been associated with the arrhythmias, very dangerous and often fatal arrhythmias in these children. Then there can be hypomagnesemia, thiamine deficiency, and thiamine deficiency can lead to different types of neuropathies in these children. So how do you have to prevent a refeeding syndrome? The idea is to start these calories slowly, and gradually, after introducing slowly calories, gradually increase them according to the tolerance of the child. Another question is on severe acute malnutrition. Now, severe acute malnutrition, I've already discussed in my classes, is a condition which is associated with a malnutrition occurring in a child between 6 to 59 months of age. So any child who is between 6 to 59 months of age and who has any one of the three criteria, you did not need had you need not have all the three criteria. Any one of the three criteria, if it is present in a child between 6 to 59 months of age, then we call it as a severe acute malnutrition. So for example, the first criteria is that the child should have a bilateral pitting edema. especially bilateral pitting edema in the legs, usually of nutritional origin. Then the child should have a weight for height which is less than 3 Z scores or less than 3 standard deviation from the expected, and then the child should have a mid-arm circumference of less than 11.5 centimeters. So a child between 6 to 59 months of age having any one out of these 3 criterias, you need not have all the 3 criterias, any one of these 3 criterias: bilateral pitting edema, weight for height less than 3 standard deviation, less than 3 Z scores, and a mid-arm circumference less than 11.5 centimeters. Any one of them may be present, and we will say this is a case of severe acute malnutrition. I have discussed this in my classes in detail, and severe acute malnutrition can be managed in the hospitals. It can also be managed at home. So complications, presence of danger signs such as persistent vomitings, unable to drink water or any fluid, unconsciousness, seizures or history of seizures, these type of danger signs, complications, severe edema, lack of appetite, all of these are indications for hospitalizing, admitting these children and managing these children in the hospital setup. Otherwise, the severe acute malnutrition can be managed at home as well. By those classical 4 A's which I have already told in my class: giving amoxicillin for a period of 5 days, albendazole single dose in children more than 2 years of age appropriate vaccination, so the children should be vaccinated for the age, and in case the child has a clinical vitamin A deficiency, then vitamin A should be given to these children. So this is all about severe acute malnutrition. Then there is a question on CHC. Congenital adrenal hyperplasia is something which your medicine faculty, Dr. Thamimani, is a very good faculty, a top-notch faculty, so he takes it. So there is no point of my telling about congenital adrenal hyperplasia. Basically, in short, what is a congenital adrenal hyperplasia? Basically, it is a group of inherited disorders in which the aldosterone, the cortisol, and the adrenal androgen secretions are primarily interfered or interrupted with because of deficiencies of different enzymes. So there will be interference in the secretions, the development and secretion of aldosterone, cortisols, and even adrenal androgens. So you have 2 basic types. One is salt wasting type of a congenital adrenal hyperplasia, and you have another type which is a salt retaining type of a congenital adrenal hyperplasia. A salt wasting type primarily presents with hyponatremia, hyperkalemia, dehydration, while the other type, in which there is primarily salt retention, that usually occurs when aldosterone levels usually are high, and ultimately in all cases of CH, the cortisol levels will definitely decrease. And because of the decrease in the cortisol levels in all types of congenital adrenal hyperplasia, there will be an increase in ACTH secretion, a compensatory increase in ACTH secretion, which stimulates the adrenal medulla, leading to hyperplasia. Stimulates the adrenals, leading to hyperplasia. That is why the condition is called as a congenital adrenal hyperplasia. So why is the name congenital adrenal hyperplasia? Because it's a group of inherited disorders in which ultimately cortisol is always reduced. Aldosterone is also reduced in many types, which is salt wasting types of CAH. But there are groups of CAH in which there may be salt retention. But ultimately in all cases there will always be cortisol deficiency, and when there will be cortisol deficiency, there will be increase in the levels of ACTH to compensate, which will cause stimulation of the adrenals, leading to adrenal hyperplasia. And since this is occurring from the intrauterine life, it's a congenital disorder. That is why it is called as a congenital adrenal hyperplasia. The most common type of congenital adrenal hyperplasia is a 21 hydroxylase deficiency, which is classically a salt wasting type of a congenital adrenal hyperplasia. 3-hydroxy beta steroid dehydrogenase deficiency again is a salt wasting type of a congenital adrenal hyperplasia, while 11-hydroxylase deficiency is more commonly a salt retaining type of a congenital adrenal hyperplasia. But I'm sure all of this will be discussed in detail in medicine, so you will not have problems in understanding CH once you have this in your medicine classes. Well, another question is on Ballard scoring. So Ballard scoring is a scoring system which has been used for assessment of gestational age. So Ballard scoring system is a scoring system which has been used for gestational age assessment in newborns. It's a scoring system for gestational age assessment in children. We are now using a modified Ballard scoring system. There are two primarily modified, the modified Ballard scoring system, which is used for gestational age assessment in newborns, has two main criteria. One is the neuromuscular maturity criteria. Neuromuscular maturity criteria. While the other criteria is the physical maturity criteria. Physical maturity criteria. There are 6 neuromuscular maturity criteria and 6 physical maturity criteria. So what is Ballard scoring doing? It is assessing the gestational age of a newborn whose gestational age is not known. So it is used to assess the gestational age of newborns using a set of 6 plus 6, 12 total criteria. 6 of them are neuromuscular maturity criteria and 6 of them are physical maturity criteria. The neuromuscular maturity criteria may include criteria such as seeing the level of flexion that can be brought at the wrist joint in a newborn. So this is called as the window sign. Then the arm recoil. So you extend the hand of the child and see how much the hands recoil, and you measure the angle at the elbow. So this is known as the arm recoil. Then you measure the popliteal angle. You also see the posture of the child. Then you also are seeing the scarf sign. So what is the scarf sign? You hold the hand of the newborn and try to bring that towards the other side. So if it is holding the right hand of the newborn, you are pulling it to the left side and keeping the elbow as the landmark. You are seeing how much the elbow can be pushed towards the other side. Naturally, more premature will be the newborn, more easier with the elbow be pulled towards the other side. So basically you are seeing where is the elbow going once you are pulling this elbow towards the other side. So is the elbow stopping at the ipsilateral mid-axillary line? Is the elbow stopping at the level of the sternum? Is the elbow stopping at the level of the contralateral, the opposite side mid-axillary line? So basically you are giving scores based upon how much you are able to pull the elbow towards the other side. And then there is a heel to ear test. So you are holding the heel of a newborn and you are trying to pull it up towards the ipsilateral ear. So you are basically assessing the neuromuscular maturity in window sign, arm recoil, popliteal angle, posture, scarf sign and heel to ear sign. So these are the 6 signs and each is given a score of -1 to +5. Actually most of them are given scores from -1 to +4. I think it's the popliteal angle which is given a maximum score of 5. All other window signs, arm recoil, posture, scarf sign, they are given a maximum score of 4. It's the popliteal angle which is given a maximum score of 5. So -1 to +5. I think this was asked in a DM neonatology exam also, this question, that which neuromuscular maturity criteria in the modified Ballard scoring is given a maximum score of +5. That is the popliteal angle. Similarly, now you see the physical maturity criteria, which includes the skin. So you observe the skin, you observe the child's eye and the ears, you observe the child's hairs, which are known as lanigo. You observe the child's plantar surface, you observe the child's breast nodules, and you observe the child's genitalia. And again, give a score from -1 to +5. Basically, what I'm trying to say is that you are using two sets of criteria, the neuromuscular maturity criteria and the physical maturity criteria. Each criteria is scored, and then a total score is found out by adding the results of these 12 criteria. So out of the total score, I think the total score is from 10 to 50. So the total score ranges from 10 to 50, which corresponds to a gestational age of, I think, 20 weeks to 44 weeks. So a total score of 10, probably corresponding to a gestational age of 20 weeks, and a total score of 50 corresponding to a gestational age of 44 weeks. But you need to cross check this, whether score of 10 is corresponding to 20 weeks and 50 is corresponding to 44 weeks. So basically you are giving a total score after adding the neuromuscular maturity criteria and the physical maturity criteria, and based upon that total score you are assigning a gestational age. So this is the modified Ballard scoring. Then please explain about necrotizing enterocolitis. So necrotizing enterocolitis is primarily a ischemic intestinal disorder. It's a ischemic intestinal disorder which is primarily seen in preterm newborns. So it's primarily a complication of preterm newborns. Only 10% newborns develop NEC. 90% of necrotizing enterocolitis develops in preterm newborns. It's a ischemic intestinal disorder of the intestine, and it is known to affect primarily the ileocolic segment. So which segment of the intestine is primarily affected? It is the ileocolic segment. So the part of the intestine which is primarily affected with necrotizing enterocolitis is the ileocolic segment. So what happens in a necrotizing enterocolitis is there is a complication which develops because of two factors coming together. One is ischemia and one is infections, intestinal infections. And that intestinal infections actually occur because formula feeds are started in the preterm. So it's very rare for breastfed newborns to develop NEC. NEC is primarily a problem seen in preterms, and that too preterms who are given formula feeds. Formula feeds such as bottle milks introduce intestinal infections. And because you are giving formula milk, so you are introducing lactose into the intestine. This lactose is acted upon by the intestinal infections, the bacteria. And what will the bacteria do to the lactose which is present in the intestine? It will cause fermentation. Fermentation of the lactose or carbohydrates inside the intestine. This leads to the release of short chain fatty acids. The end products of fermentation are short chain fatty acids, and this short chain fatty acids primarily leads to metabolic acidosis. So metabolic acidosis is a very important problem that is seen in NEC as a result of lactose being fermented by the intestinal bacteria. The combination of ischemia and metabolic acidosis along with intestinal infections, they all contribute to inflammatory damage to the intestine, And this inflammatory damage to the intestine is called as a necrotizing enterocolitis. It is often associated with lab markers such as anemia. It is associated with thrombocytopenia. So platelet counts often come down in these cases. It is often associated with leukopenia as well. Mild cases of NEC may be associated with leukocytosis, neutrophilia. But severe NEC cases usually lead to a neutropenia, leukopenia. So combination of anemia, thrombocytopenia, leukopenia and metabolic acidosis. These are the typical lab findings in NEC. So these newborns typically start having from 2nd to 3rd week gradual abdominal distension, increasing collection of milk in the intestine, which we call as increasing gastric residues, and bleeding in the stools. So when the intestinal mucosa is damaged, there is bleeding in the stools, and this blood in the stools contributes further to the development of anemia in these children. X-ray of these newborns often shows a typical pattern which is called as pneumatosis intestinalis. Pneumatosis intestinalis. That's a pathognomonic radiological sign of NEC. It is gas which is present in the bowel wall. Treatment is usually the early part of NEC. We normally classify the severity according to the Bell staging. So while stage 1, which is many times considered to be presumed NEC, may be managed medically by keeping the child nil per oral, giving antibiotics to the child, recurrent gastrointestinal aspirations. But stage 2 and stage 3 NEC, which is definitive NEC, stage 2 is definitive NEC, and stage 3 is advanced NEC with complications. Those usually are managed surgically. And there have been some reports that if you give corticosteroids, antenatal corticosteroids to pregnant women, especially women who are delivering babies between 24 to 34 weeks, giving dexamethasone 6 milligram intramuscular twice daily for 2 days, 4 doses total, it can significantly reduce the risk of NEC along with many other disorders such as the severity of hyaline membrane disease. Respiratory distress syndrome can be reduced. There can also be reduction in severe IVH, intraventricular hemorrhages in these cases. Plus, giving antenatal corticosteroids can also reduce the risk of periventricular leukomilatias. That's the ischemic brain injury in preterm babies. So many benefits of giving antenatal corticosteroids. Then growth charts. See, growth charts basically are charts which are used for evaluation and cross-checking whether the child is growing normally or not. We have the primary growth chart that we use in our day-to-day practice has a 50th percentile curve, which is the curve we normally want, along which the child's growth should be present. Then we have 25th centile curve, a 10th centile curve, and a 3rd centile curve. Then we have a 75th centile curve, a 90th centile curve, and the 97th centile curve. So anything which crosses the 97th centile curve or comes down below the 3rd centile curve is always abnormal. So for example, we are using the pink growth charts for girls. So if you are using a growth chart for a girl and we are plotting the height and the weight of the girl, so one side has the age, the other side has the height and the weight. So suppose the height of the child or the weight of the child crosses the 3rd percentile, that means goes below the 3rd percentile or goes above the 97th percentile. For example, let me tell you, for example, the head circumference crosses the 97th percentile. We call it as a macrocephaly. It should ideally lie on the 50th centile. But till the time it is on the 50th centile, it is normal. The moment it starts growing above or below, at that time there is a problem. But the maximum problem occurs when the growth of the child crosses the 97th percentile or the 3rd percentile growth curves on the chart. Usually a preterm will not be evaluated on a growth chart because these growth charts are primarily for evaluating terms. After 2 years of age, usually a preterm's growth can be evaluated on the standard growth chart. So we need to be very careful when you are plotting the growth of the child on a growth chart, because a preterm child's growth cannot be evaluated on the growth chart which is primarily used for term newborns. And in case you are using a preterm's age on this growth chart, then you have to use the corrected age. For example, if the preterm is 6 months of age and is 3 months premature, so his corrected age will be 6 months minus 3 months. An example is the preterm child is born at 28 weeks gestation. I'm just giving you an example. The preterm child is born at 28 weeks gestation. Taking 40 weeks as the cutoff, 40 weeks as the normal cutoff. A 28 weeks gestation child means he's 12 weeks preterm. 12 weeks preterm means he's 3 months preterm. He was born 3 months earlier than 40 weeks. So now when that preterm will be 6 months of age, I will not be plotting his age as 6 months on the growth chart. I will be plotting his age as 6 months minus 3 months, which is 3 months on the growth chart. So what I'm doing is I'm plotting the corrected age of a preterm. After 2 years, we use the same age. But till the age of 2 years in a preterm, we use the corrected age in a preterm. So I hope you have understood about the growth chart. Okay, so there is a question. Please update video on counseling for NEET PGs. Sir, I secured 4028. I am from Jaipur. Please share the list of orders of colleges for counseling, either your number or email to connect. Sure, you can always connect me on pankaj.tikku@gmail.com. If you want any assistance, please feel free to connect at pankaj.tikku@gmail.com. Otherwise, you can put the query on DBMCI Premier page also, where also I would be able to help you out in whatever best capacity I can help you out. Then there is a question on chart for management and diagnosis of celiac disease. So celiac disease actually is a type of a gluten sensitive enteropathy. And I presume what question is being asked is probably they're asking the chart that I normally make in my classes for the diagnosis and management of celiac disease. It's a very extensive chart, so probably the time will be too short. I won't be able to explain the whole chart here. But primarily what I tell in my classes is that first you have to go in through a transglutaminase antibody testing, TGA, transglutaminase antibody testing. If the levels of transglutaminase antibodies are considerably raised, which means raised to almost 10 times the normal value, in those cases you go in for an endomysial antibody testing and you go in for an HLA DQ2 and DQ8 testing. But in case the transglutaminase antibodies are raised but are raised to less than 10 times the normal value, they are raised but raised to less than 10 times the normal value, then you do not rely on endomysial antibody and HLA DQ2, DQ8. You rather rely on small intestinal endoscopy. To establish the diagnosis. And those classical histopathological changes that you will see, on small intestinal endoscopy, including increased intraepithelial lymphocytes, villus atrophy, and crypt cell hyperplasia, those changes, if they are present, then you will say this is celiac disease. Furthermore, in this case, if the endomysial antibody and endomysial antibody and HLA testing both are positive, obviously you treat it as a celiac disease. In case the endomysial antibody and HLA-DQ2 both are negative, then you might consider a diagnosis of a false positive transglutaminase antibody levels. And in case one of these tests is positive, say endomysial antibody is positive, HLA is negative, or HLA is positive, endomysial antibody is negative, in those cases you may go in for a small intestinal endoscopy to confirm the diagnosis. So this is the flow chart which we can follow in children who come to us with the symptoms of celiac disease. Then there is a question on Porter and Bechtel syndrome. Porter syndrome is commonly associated with bilateral renal agenesis. Porter syndrome includes pulmonary hyperplasia, oligohydramnios, twisted skin, which is wrinkles present on the skin. Then there is a twisted face, and when I say twisted face, that means there is an abnormal face which we call as Porter's face. Then there is extremity defects, so defects of the extremities, and then there is renal defects. And as I told, the most common association with bilateral renal agenesis is with Porter syndrome. Bechtel syndrome, on the other hand, is another syndrome, and this is more commonly associated with a unilateral renal agenesis, single kidney absent, and this includes vertebral defects. A includes anorectal malformations. C stands for cardiac defects. TE stands for tracheoesophageal defects. So TE stands for tracheoesophageal defects. R stands for renal defects, and as I told you, unilateral renal agenesis. And L stands for limb defects or limb abnormalities. So I always teach this in my classes, that Bechtel syndrome is commonly associated with a unilateral renal agenesis, while Porter syndrome is commonly associated with a bilateral renal agenesis. Asthma treatment protocol. Well, asthma treatment protocol as per the guidelines, again it's very a very extensive protocol, so very difficult to complete it in this short time. But anyway, in children less than 5 years we have a separate protocol usually, and in children between 6 to 11 years we have a separate protocol. So in children who come to us less than 5 years of age, the reliever drug and the maintenance drug. Maintenance drug, as you know, is a drug which is given daily to control the frequent relapses or frequent exacerbation of asthma symptoms. It's also known as controller therapy, maintenance therapy. Reliever or rescue therapy is usually given SOS, as needed therapy, when there is symptoms which are very acute, severe. So what they say is step 1 treatment. So step 1 treatment, what they say is reliever should be SABA inhaler or a SABA by nebulizer. Maintenance is not required at step 1. At step 2, in children less than 2 years of age, they say again SABA can be used as a reliever, and for maintenance you either may use a low dose inhaled corticosteroid daily, or you may use a leukotriene receptor antagonist. You can choose one of them, and these treatment needs to be given daily. For step 3, again SABA can be given as inhaler in case of SOS, and here you would like to add a low dose inhaled corticosteroid with a leukotriene receptor antagonist. So in step 2 we were giving either leukotriene receptor antagonist or we were giving low dose inhaled corticosteroid. Obviously low dose inhaled corticosteroid is always preferred as the gold standard control of therapy. But in step 3 you may add inhaled corticosteroid to a leukotriene receptor antagonist, or you may give double the low dose of inhaled corticosteroid. So we were giving low dose inhaled corticosteroids in step 2. In step 3 you can either double the dose, or to the low dose of inhaled corticosteroid you add a leukotriene receptor antagonist. Step 4 obviously is a treatment where you would require an expert consultation, expert guidance, along with the continuation of management, since the asthma symptoms are apparently getting uncontrolled. Coming to children who are between 6 to 11 years of age. Now here a step 1 treatment, again I will divide it into 2 parts. One is reliever and one is maintenance. So step 1 treatment, again they say, is a short acting beta agonist, but along with the short acting beta agonist they say a low dose inhaled corticosteroid may be used as needed. So whenever there are acute symptoms, rather than using a short acting beta agonist alone, you can add a low dose inhaled corticosteroid with a short acting beta agonist. Maintenance treatment again is not required at step 1. In step 2 they say that maintenance treatment can either be a low dose inhaled corticosteroid or a leukotriene receptor antagonist. And in case you are giving low dose inhaled corticosteroid now daily as a maintenance treatment, then only short acting beta agonist may be required as a reliever therapy. No need of giving SABA with the inhaled corticosteroid as a reliever therapy if you are giving low dose inhaled corticosteroid daily as maintenance therapy. Step 3, so now you are further up titrating the treatment. So in step 3 what they say is either you can use a low dose inhaled corticosteroid and to it you add a leukotriene receptor antagonist. So now what you are doing is you are adding a leukotriene receptor antagonist like salmeterol, formoterol to a inhaled corticosteroid low dose, or you are increasing the dose of inhaled corticosteroid and giving medium dose inhaled corticosteroid. Third option, which is not very preferable, is to a low dose inhaled corticosteroid you may add a leukotriene receptor antagonist. And a fourth option that they are giving in step 3, this is primarily as per the GINA guidelines, 2021 guidelines. What they are recommending is that you can give a combination of inhaled corticosteroid along with formoterol. Inhaled corticosteroid along with formoterol. And we have budesonide formoterol combination available. The only, I think, marketed formulation right now of inhaled corticosteroid with formoterol is budesonide formoterol combination. 100 micrograms of budesonide with 6 micrograms of formoterol. And use this in very low dose. Use this in very low dose. And use it both as a maintenance treatment also, plus use it as a reliever treatment also. So now no need of giving SABA separately as reliever and a separate maintenance. Use this combination, very low dose of inhaled corticosteroid formoterol combination as a maintenance and a reliever therapy also. In step 4, so you are basically up titrating step 3 treatment. So in step 3 you were giving low dose inhaled corticosteroid with the long acting beta agonist. So this is long acting beta agonist. So now in step 4 you will give medium dose inhaled corticosteroid plus a long acting beta agonist, or another option which is available is, instead of giving very low dose of inhaled corticosteroid formoterol combination, you give low dose of inhaled corticosteroid formoterol combination and again use it as a maintenance treatment plus reliever treatment. So in step 3 you were giving very low dose of inhaled corticosteroid formoterol as maintenance reliever, 106 micrograms, while in step 4 you are giving low dose. So from very low dose you have increased in step 4 to low dose, which is 200 micrograms of budesonide, 6 micrograms of formoterol. So you are basically up titrating the treatment. And in step 5 obviously you have a very poorly controlled asthma, so you might like to give add-on treatments such as a short course of systemic steroids, or you might like to add omalizumab, IgE monoclonal antibody. You might like to give mepolizumab. So these are add-on treatments which may be preferred in children with add-on treatments: omalizumab, mepolizumab, short course of steroids. These can be tried in step 5. So I hope you have understood about the management algorithm for asthma in children. Then there is a question on respiratory distress scores. Well, there are two main respiratory distress scores in newborns. There are two main respiratory distress scores in newborns. One respiratory distress score is the Silverman-Anderson score, which is primarily a score which is used in Silverman-Anderson score, which is primarily given as a score for preterms. And then there is a Downs Vidyasagar score, which is a score which can be used in both terms and preterms. Silverman-Anderson is primarily for preterms. For example, a preterm with neonatal respiratory distress, the Silverman-Anderson score is primarily used. So these are the respiratory distress scores for newborns. Each of these scores have 5 criteria. For example, the Silverman-Anderson score: xiphoid retractions, lower chest retractions, upper chest retractions. The mid-axillary line is taken as the cutoff. So retractions above the mid-axillary line will be upper chest retractions, while retractions below the mid-axillary line will be lower chest retractions. So for Silverman-Anderson score, you have xiphoid retractions, lower chest retractions, upper chest retractions, grunting, sound coming from the mouth, and nasal flaring. So 5 criteria. So there are total of 5 criteria. This is the one which is more commonly used, 5 criteria. And each criteria is given a minimum score of 0 and a maximum score of 2. Minimum score given is 0, which means the best score for each criteria, and the maximum score is 2, which means the worst score. So for each criteria, the minimum score is 0, which is the best score, and the maximum score is 2, which is the worst score. So for 5 criteria, that means that total score is 10. So those who score 10 out of 10 have actually the worst condition. Those who score minimum have a good condition. For example, they say if a child's total score, I'm talking about total score, Silverman-Anderson score, is between 0 to 5, it means the child only has a mild respiratory distress. He can be managed by just giving oxygen. If a child has a score from 6 to 7, the child has a moderate respiratory distress, which means he will require distending pressures such as CPAP for improvement. And those children who have a Silverman-Anderson score of more than 7 means they have a very severe respiratory distress and usually will require intubation and ventilation. So basically these are scores which are primarily given for evaluating respiratory distress in newborns. And please remember, the Silverman-Anderson score is primarily used for preterm babies. We have this other score which is known as the Down score also. The Down score is also there. The Down score can be used for preterm babies and for term babies also. But the Silverman-Anderson score is primarily used as a score for preterm babies. Down score again has 5 criteria. So what are the 5 criteria of Down score? The 5 criteria of Down score are grunting, respiratory rate, airway entry on both sides, chest retractions, and cyanosis. So there are 5 criteria of Down score and 5 criteria of Silverman-Anderson score. As I told you, the Silverman-Anderson score, the 5 criteria are xiphoid retractions, lower chest retractions, upper chest retractions, grunting, and nasal flaring. And the Down score are grunting, respiratory rate, airway entry, chest retraction, cyanosis. And both cases, if the newborn scores between 0 to 5, that means the newborn has a mild respiratory distress. If the newborn score between 6 to 7, that means the child has a moderate respiratory distress. And if the newborn scores more than 7, that means the child has a severe respiratory distress. All mild respiratory distress can be simply be managed by oxygen devices, such as an oxygen by hood. Children with scores between 6 to 7 usually have moderate respiratory distress and require distending pressure, such as continuous positive airway pressure therapies. And those children who have a score of more than 7 have severe respiratory distress. These scores have been asked in the exams. I remember in AIMS there was a question in which a case study was given. Case study of a child in a respiratory distress. And they asked what is the score of this child, the Silverman-Anderson score. So both times, I think there have been 2 times this question has been asked, and in both cases it's the Silverman-Anderson score which has been inquired. So these are important respiratory distress severity scores which are used. And please also, one more thing, please also, I've seen students getting confused between the term tachypnea and respiratory distress. Please remember, tachypnea and respiratory distress are not the same. This I have repeatedly emphasized in my classes. And you should be very clear about it. Tachypnea and respiratory distress are not the same. There are 2 different terms. Although there are overlaps, but there are 2 different terms. For example, a respiratory distress in a newborn includes any 2 of the following. Any 2. And I'm talking about newborns. So either the newborn has tachypnea, or the newborn has chest retractions, or the newborn has tachypnea is there, chest retractions is there, and groaning or grunting is there. Tachypnea is simply fast breathing. In newborns, it is respiratory rate more than 60 per minute. So respiratory distress in a newborn is considered to be present when any newborn has minimum two of these three criteria, minimum two. Which three criteria? Either the newborn has tachypnea, or the newborn has chest retractions, or the newborn has grunting or groaning. Grunting or groaning. So out of tachypnea, chest retractions and grunting or groaning, any two out of three, if they are present, we say that the child has a respiratory distress. And this is, I'm talking about newborns. And a respiratory distress will be managed by different treatment options, but only after the child has been stratified into one of these criteria: mild respiratory distress, moderate respiratory distress, and severe respiratory distress, according to Silverman-Anderson scoring system or the Down scoring system. Then there is a question where a student has asked, is handedness, what sir, handedness का meaning क्या होता है? Handedness basically means whether the child is using his predominantly right hand or left hand to pick up objects. I think this is what you are meaning by asking me what is handedness. Handedness means predominantly the child is right-handed or left-handed. A child is known to become predominantly right-handed, left-handed, or right hand left hand discrimination usually develops by the age of 4 years. But if they say what is handedness, handedness means कि बच्चा चीज को उठाते समय, whenever the child is picking up objects, कोई भी बच्चा चीजों को उठा रहा है, is he using predominantly the right hand or the left hand to pick up the objects? वो चीज को ज्यादातर right hand से चीज को उठा रहा है या left hand से चीज को उठा रहा है? This is meaning of handedness. Another question is pneumonia guidelines change हुई हैं क्या? Not as far as I know. अगर मुझे पता चलेगा कि pneumonia की guidelines change हुई हैं, I'll come to know. I'll definitely inform you. As far as I know, I treat the classical IMNCI treatment guidelines for pneumonias in children who come to you in primary healthcare, the IMNCI treatment guidelines. So the integrated management of neonatal and childhood illnesses treatment guidelines, they primarily divide the child who comes to you with cough or with pneumonia into either cough and cold or into pneumonia or into a very severe pneumonia or very severe disease, pneumonia or a very severe disease. Cough and cold का मतलब होता है, what is meant by cough and cold? Cough and cold primarily means that the child is presenting a cough, but there is no fast breathing or there is no respiratory distress. Pneumonia का मतलब होता है, pneumonia means, primarily means that the child is presenting with tachypnea or the child is presenting with fast breathing, with the respiratory distress, chest retractions. So either the child is presenting with tachypnea, fast breathing, or the child is presenting with chest retractions. In both cases, we say that the child will have pneumonia. And presence of danger signs. I told you about the danger signs. Presence about the danger signs or a stridor occurring in an otherwise calm child. A stridor in an otherwise calm child. In these cases, we say that the child has a severe pneumonia or a very severe disease. So, IMNCI, Integrated Management of Neonatal and Childhood Illnesses, have divided the cough in the child into three main criteria: cough and cold, or three main categories. Cough and cold, where the child is presenting without any fast breathing or without any chest retractions. So in such cases, the child does not require any antibiotics. You just need to manage the child symptomatically, send the child back home and call the child back, follow-up visit planned after 5 days. For pneumonias, well, tachypnea or fast breathing, which is tachypnea, and the second is chest retractions. Any one of them may be present. So the child presenting with fast breathing, this will also be pneumonia. And the child presenting with chest retractions, this is also pneumonia. And since fast breathing or chest retractions indicates pneumonia, well, these children will require antibiotics. So a 5 days of antibiotic course and an amoxicillin course, along with management of cough, and a follow-up visit planned after 2 days is required. In all cases, if cough lasts for more than 2 weeks, in those cases, tuberculosis needs to be, the COX needs to be ruled out. And for all children who present to you with danger signs or present to you with a strident, otherwise calm child, well, this is a case of a severe pneumonia or a very severe disease. This is something which should not be managed in the primary health center. This definitely requires an immediate referral to a higher center. Even in pneumonias, if the child's oxygen saturation falls to less than 90%, that again based upon the IMNCI program is again an indication for immediate referral to a higher center. Regarding very severe disease or a severe pneumonia, the child will require oxygen to be given, and this oxygen, if it is available, it can be given. Otherwise, amoxicillin can be given or ampicillin can be given along with gentamicin. So you might give 1 IV MP, 1 IV Genta, 1 start doses, and immediately the child should be referred to a higher center. So you should not wait here. The child who is having a severe pneumonia or a very severe disease should be immediately referred to the higher center. So this is as per the IMNCI guidelines. I'm not very sure whether these guidelines have changed, because at least I have not got any update regarding this, that the guidelines have changed. In case I'll come to know that the guidelines have changed, I'll definitely inform you. If there is any other question, I think we have reached the end of the class also. But anyway, if there is still any query, I'll wait for 1 minute more. If there is any query, please feel free to ask. I hope this session was useful for you and you have understood the queries that I've tried to explain, all your queries. In case there is any more query, please feel free to ask. Because ultimately what you have to prepare for these exams is basically using MCQs. Please use MCQs as much as possible. Our question banks are having a lot of MCQs. We have seen the question banks. We have tried to prepare next based type of question banks in which the questions have been prepared. Many of them have been prepared in case format series. So we are trying to make those question banks as accurate as possible. So I think you should go through our question bank, the eGurukul question bank. Those questions you can attempt, you can prepare, and if there is any questions that you feel are difficult, you have not been able to understand the concept behind those questions, you can feel free and ask those questions. But ultimately, please prepare yourself thoroughly by answering as many questions as possible. And we have a large list of questions in our question banks. For my classes, I've already told about the important topics, especially milestones, very important topics. Growth is an important topic. Neonatology, malnutrition. In neonatology also, specifically the general neonatology part, respiratory distress scores, necrotizing enterocolitis, complications of preterms, neonatal jaundice. Then congenital heart diseases, very important topic. Both the acyanotic and cyanotic heart diseases, fetal circulation and the transition from fetal to neonatal circulation, PPHN, persistent pulmonary hypertension of the newborn. So all of these are important topics. And neurology. Neurology is selected topics like neural tube defects, very important, especially the dose of folic acid in neural tube defects, hydrocephalus management. Then very important for you to know about epilepsies and seizures, meningitis in children, cerebral palsies, neurocutaneous disorders, especially Sturge-Weber and tuberous sclerosis. Then moving on to nephrology, glomerulonephritis, nephrotic syndromes. And let me tell you, recently I was going through the nephrotic syndrome. Students have been asking, there's a lot of confusion related to the steroid resistant nephrotic syndrome. And the standard definition that is given in many standard textbooks is child failing to respond despite 4 weeks daily, 8 weeks of total steroid therapy. That's a definition given Nelson also. Failing to respond despite 8 weeks of steroid therapy. But yesterday we went through a guideline, I think ISPN. So there they had written 6 weeks of steroid therapy. So no response, 6 weeks of steroid therapy. I think it was 2021 issue that I came across. So no complete remission or complete disappearance of proteinuria despite 6 weeks. Now I will still follow what is given in Nelson's textbook of pediatrics, but it's important to tell you what have been given in authentic guidelines, and these are also very authentic guidelines. So there are certain debatable points, and we need to keep on cross-checking with the latest updates. You have any queries, please feel free to forward me those queries. And I hope this doubt solving session was helpful for all of you. So since we do not have any other query, thank you very much, and it was lovely talking to you on this platform, and we'll have more of such doubt solving sessions every month. So thank you very much, and goodbye.